Good evening, everybody. My name is Dr. Rima Saif, and I would like to talk about imaging thoracic infection inside out. My talk will be divided into three groups. I will talk about infection in the lung, then into the pleura, as well as infection involving the chest wall. And the objectives of my talk is imaging manifestation of lung infection with importance of clinical information in the diagnosis of respiratory tract infection, pleural cavity infection and its mimic with the role of thoracic intervention procedure in the management and treatment. Finally, we'll close up with a role of MRI in chest wall infection. Starting with the first case, this is a chest X-ray for a 60-year-old male patient showing an abnormal opacity in his chest X-ray. We can see a well-defined rounded opacity in the left apex with air lucency, crescent shape in its upper margin associated with fibrotic bands, atelectasis, volume loss, along with a mediastinal shift. This finding suggestive of a fungal ball. However, Pancoast tumor and the neurogenic tumor are within the differential diagnosis and should be ruled out. CT scan was performed and confirmed the presence of a fungal ball within a pre-existing cavity, which shows multiple calcification within associated with the bronchiectasis, atelectasis, volume loss, trachea being shifted to the left side, as well as regional emphysema. As routine in chest disease hospital, we'd like to do brain images to check the mobility of this soft tissue lesion. Since a fungal ball usually is mobile, however, if this is a cancer, the mass lesion will be fixed and it will not be moved. Finally, we reach a diagnosis of the chronic pulmonary aspergillosis. So, pulmonary aspergillosis is a collective term used to refer to a number of conditions caused by infection with a fungus, usually Aspergillus pygmatis, the most common species. Clinical manifestation and extent of lung involvement depends on two factors, host factor and the fungal factor. Host factor is usually depend on the patient's immune state and the underlying lung, if it's normal or if there is a pre-existing disease. A fungal factor is inhaled conidial and virulence of the organism. Aspergillosis or Aspergillus syndrome, there is a multiple clinical manifestation, and namely they are a simple aspergillosis, chronic pulmonary aspergillosis, allergic bronchopulmonary aspergillosis, and invasive aspergillosis. Each of them has its specific imaging or characteristic imaging finding with a certain immune status. Simple aspergillosis is a fungal ball seen in a pre-existing lung cavity showing a mobile mass with an air crescent sign. Usually the patient is asymptomatic and being immunocompetent. 10% shows a spontaneous regression. However, in our case, chronic pulmonary aspergillosis, the mycetoma or the fungal ball pre-existing in a cavity, usually associated with other findings such as consolidation, pleural thickening, bronchiectasis, emphysema, and the bronchopleural fistula. Usually seen in immunocompromised host, and it's a progressive with a high mortality rate. Chronic pulmonary aspergillosis has three subtypes, cavitary, fibrosing, and necrotizing. In cavitary type, 90% of the patient have a positive Aspergillus immunoglobulin antibody, and usually their images shows a destruction and fibrosis in at least 2 lobes. Fibrosing aspergillosis, it's an academic day with imaging, academic terminology with imaging finding overlapped with a cavitary type, And finally, necrotizing pulmonary aspergillosis, there is a pre-existing infection of non-tuberculous mycobacterium infection. My second case is a 60-year-old male patient with a chest X-ray showing abnormal opacity. This opacity being a perihilar, nodular, more or less linear or streak-like, and there is again a heterogeneous opacity in the right lung. So the opacity is perihilar, central, and predominantly noted in the upper lobes. And the differential diagnosis for this appearance is pneumonia, TB, sarcoids, and bronchiectasis with a mucus plug. CT was performed for this patient showing a bronchiectasis with bilateral dilated tubular structure, fluid-filled, along with a regional centrilobular nodules, some of them being showing a branching and a tree and bud pattern, and the other being just isolated centrilobular. In the right upper lobe, we can see a branching opacities in which we can call it a finger in a glove. And this opacity in a lung window being a bit hyperdense compared to a usual mucus plug within the dilated airway. And this leads us to a diagnosis of allergic bronchopulmonary aspergillosis. This is a manifestation of an exaggerated immune response to aspergillus via type 1 and 3 hypersensitivity responses, almost always affecting patient known case of bronchial asthma or cystic fibrosis. Patient symptoms usually on and off. They may present with hay fever, with or without cough, and the lab usually showed peripheral blood eosinophilia. Early diagnosis and early treatment is really important to limit the disease progression to fibrosis and irreversible bronchiectasis. Imaging feature, as we saw, it's a transient changes with the fleeting consolidation, bronchial wall thickening in a pattern of a tram-track shadowing, bronchiectasis with a dense mucus. Sometimes we can see air fluid level, spontaneous pneumothorax, and in a complicated cases, we will see a fibrosis with a volume loss. And this is our patient with a 2 years interval post-medication showing an improvement of the previously seen nodularities and opacities and bronchiectasis with minor residual of dilated airways and a small bronchocele in the left upper lobe. Case number 3. This is a 69-year-old male patient with incidental nodule on the right upper lobe. This nodule was FDG avid with high SUV value. The differential diagnosis for such appearance is infectious and inflammatory versus neoplastic. A zoomed view shows more feature of this nodule, which shows a minor speculation with surrounding gland-glass opacification. The differential diagnosis for such pattern can be a fungal infection, mycobacterial infection, septic emboli, and neoplastic etiology. This patient was an ex-smoker and he doesn't want to wait for a 3 to 6 months follow-up, and he was anxious and he preferred to do a lobectomy and take this nodule out since the malignancy was one of the differential. After the operation, the histopathology result came back as an invasive aspergillosis, and retrospectively we knew that this is a patient with a known case of a bronchial asthma, and he was on a long term of a steroids therapy. So invasive aspergillosis typically affect immunocompromised host with a poor prognosis and rapid progression, and extrapulmonary dissemination represents a high mortality rate. And there is 2 subtypes of invasive aspergillosis, angioinvasive and airway invasive. Angioinvasive aspergillosis causes a coagulative necrosis and vascular thrombosis. Airway invasive causes an obstruction and ulceration. Ulceration usually seen at the anastomosis site in lung transplant patients. Imaging feature of invasive aspergillosis is a halo sign and a tall sign, which is a reversed halo sign. These signs are characteristic but not pathognomonic, and it results from a hemorrhagic components either around the lesion or within the lesion. Take-home message: aspergillosis is a complex disease. A clinical history, immune state, support, and aids the diagnosis. Imaging findings are variable and may overlap, and TB should remain on the list of differential diagnosis along with malignancy. Second part of the talk about a pleural disease, we have a chest X-ray for a 30-year-old male patient with abnormal opacity noted in the left hemithorax associated with the blunting of the left costophrenic angle, raising the possibility of pleural effusion, either exudate, transudate, or a pus collection. CT was performed showing an elliptical collection with thickened pleura, more or less homogeneous content, and we can see an obtuse angle along with the costal surface and compression of the adjacent lung tissue. These are the imaging feature of empyema, and in chest disease hospital, usually we manage these cases with insertion of pigtail catheter, and this is a chest X-ray which shows successful drainage post-catheter insertion. Empyema is an infected purulent and often loculated pleural effusion, life-threatened condition, result as a complication of underlying pneumonia or subdiaphragmatic abscess or esophageal perforation. There are multiple microbial agents that can result in empyema or causes empyema, and a lung abscess remain within the differential diagnosis, especially if the abscess located at the periphery of the lung. This is a mimicker case. She's a 28-year-old female complain of fever and chest pain with abnormal opacity in her chest. We can see that we have a homogeneous opacity in the right hemithorax with air fluid level. The differential diagnosis include lung abscess, infected bulla, and since the opacity merged medially with the mediastinum, we need to rule out a bronchogenic cyst. It was performed, of course, with contrast, which shows a very large rounded abscess epicenter on the right lung, showing a thick enhancing wall with the fluid level abutting the cardiac margin. And these coronal images showing the abscess with an area of vascularities and airway that can be seen at the margin of this abscess. Again, in chest disease hospital, usually for a selected cases, we insert a pigtail catheter to drain this abscess, and this is a chest X-ray post-drainage which shows successful drainage. Lung abscess is a circumscribed collection of pus within the lung. Again, it's a life-threatened condition. Incidence reduced with the widespread antibiotic, however, increased in the era of having immunocompromised patient. Lung abscess can be primary as a result of infection or secondary related to obstructive carcinomas. Comparing empyema and abscess, which is a pleural disease versus a lung disease, empyema treated by percutaneous drainage with or without of injection of fibrinolytic agents. However, abscess well known to be treated by antibiotic only. Trial of a drainage was performed since 1938 and 1954 by percutaneous drainage and endoscopic drainage, but it is still not widely established. Review articles suggested that lung abscess can be drained under a certain indication, that is failed medical treatment, patient unfit for surgery, patient in the ICU and he or she on a mechanical ventilation, when the abscess size is more than 3 centimeters, then we can drain it by a catheter. Sick patient liable to complication and they are not fit for lobectomy, they are better to be managed with intervention procedure. And review articles suggested and concluded that the drainage is safe and effective, and it has advantage of less complication with reduced mortality rates. Other article shows a technique and a procedure how to drain this abscess with a selected criteria. They conclude that the peripheral abscess, we can drain a peripheral abscess and we need to avoid passing our catheter through a normal lung to prevent the complication of hemothorax, biothorax, or pneumothorax. And before we drain any abscess, we need to rule out bronchial obstruction and we need to rule out bronchogenic cancer because these cases should go to surgery. Take-home message: the role of catheter drainage in lung abscess remains controversial. This procedure has not gained a widespread popularity. Reported cases concluded that percutaneous thoracic drainage is safe and effective method treating lung abscess and consider an alternative to lobectomy in critically ill patients. Also, it is useful in fit patients for surgery. My last case about a chest wall infection, and this is a 30-year-old healthcare worker presented to thoracic surgery clinic with painful bulge on the anterior chest wall. There is no fever, no skin changes, but there was a history of recent travel to Thailand. His CT shows an asymmetry in the chest wall with a large, bulky, soft tissue, abnormal soft tissue area in the right chest wall involving with destruction, rarefaction of the sternum and the first and second rib. This collection shows a relatively low central area. We did MRI for this patient, and this image shows the mass. T1 shows a mass showing a signal intensity iso-intense to the muscle. However, in T2 series shows a bright signal intensity within the center of the lesion, and as well as a changing in the marrow density of the adjacent sternum. Diffusion weighted image showed a significant restricted diffusion of this lesion with remaining central area of non-restriction. The measured ADC value gave a variable numbers of high and low value, which goes with which was a bit confusing because when the lesion shows a diffusion, we are suspecting a malignancy. However, the area of breakthrough make us thinking of an infection, and the differential here was either a tuberculous infection versus chondrosarcoma. So we proceeded and we went through and we did a biopsy, and the biopsy came back as a tuberculous infection. A take-home message of this case mentioning the role of MRI in evaluating of chest wall lesion. It's a high contrast and high spatial resolution with lack of risk of ionizing radiation, and the fusion weighting image is useful compared to PET-CT in getting an answer for such lesions. And indication of biopsy in infection, sometime when we didn't get a proper answer in imaging, we need to get a tissue sampling that help the physician treat the patient with confidence. I hope it was informative, and thank you very much for attending.